Hello again, welcome to our YouTube channel. You are with Dr. Gasanga Patrick. We are going to discuss today about burns in the pediatric population. This is a very important topic, either for a medical student, or for a resident, or you are an undergraduate. We are going to discuss about the management, diagnosis, and anything or any management related to burn in the children. This is a case study. 11 months was brought in by parents with scarred burn. Infant was wrapped in a wet towel and is screaming. Infant is tachypneic but with no retraction and color is normal. Initial assessment, pediatric assessment, triangle, no appearance, normal breathing, normal circulation, appearance is normal. Vital, heart rate 140, respiratory rate 42, temperature 47.8, oxygen 98%, and weight 10 kg. Initial assessment, the member is an emergency. You have to approach by ABC, airway, nostril, B, tachypneic but normal breath sound, C, tachycardic with strong peripheral pulse, capillary fill less than 2 seconds, alert and in pain, moving all extremities and leisure scarred burn to face, trunk and left arm. Faculty district and third physical examination, mother was cooking when the 4-year-old sibling pushed the 11-month-old in stroller into the mother, causing a boiling water to spill onto infant. Infant was wrapped in cool towels and brought to emergency department 3 minutes from their home. Infant has no significant medical question in development normally. Physical exam, splash burn with blistering on nose, cheek, and 8% of chest and 50% of left arm and left thigh. No burns to back, groin, palms, or sore. What is the general impression of this patient and management priority? This is critical burn. So management priority, you have to obtain vascular access. Any burn patient need IV fluid. Then you have to begin fluid resuscitation using Parkland formula and administer pain medication and to cover burn with dry dressing. So as epidemiology, it is estimated that around 99,000 children have burn related injury annually, and the scarred burn are more common. Trauma-related injury more often occur in children, older children, including those playing with lighters or matches or stoking fires with flammable liquids. This is like a pathophysiology. Most of the time, in the case of burn, there will be disruption of transmembranous of sodium ATPase, which can lead to cellular edema as is sodium retention that in water. There can be release of inflammatory mediators like and even then vasoconstriction, systemic irritation. Then there will be systemic inflammatory response. So once the mediator rests, then they can cause those symptoms like the swelling in the case of burn. So in the case of burn, there should be extent of burn is influenced by 3 factors, either duration of exposure, how bad is the intensity of the energy, and even the type of tissue that has been injured. So duration of exposure, this is very important. At 49 degrees Celsius, if you pass, if the body pass at 10 minutes on the first, require at 49 degrees require minimum of 10 minutes to be injured. But if you are at 44 degrees, require minimum of 40 seconds to develop full thickness burn. So at 60 Celsius degree, only 3 seconds it's enough to be burned. Then at 70 Celsius degree, only 1 second it's enough to become burned. So duration of exposure is very important. So the more the temperature increase, the lesser time required to be burned. At 49 Celsius degree, at least 10 minutes. At 54 Celsius degree, 40 seconds. At 60, 3 seconds. At 70, 1 second. At 100 Celsius degree, this is 0 second. To be immediately once you become in touch, you become burned. The risk factor of burn. The most important risk factor to develop a burn is low socioeconomic status or poverty, overcrowding, or infant or children, cooking or caring for other children. This is very important. So clinical features of burn, like how to classify burn. There are first degree, second, fourth degree burn and even third. So the first degree burn, the simple thing to know, first degree burn, it involves only the epidermis and there will be no blisters for first degree burn. This is occur in the case of, and it's painful of course, and the branch with pressure, like in the case of sunburn and or minor scars. For the second degree burn, there will be blisters. Blisters is very important, involve epidermis and part of dermis. Remember, blisters form even in 24 hours and they are painful in the branch of pressure. This may heal with 7 to 21 days, and there will be no scarring in case of first degree, second degree burn. Sometimes they call it superficial partial thickness. Deep partial thickness, like if you have progressive to third degree burn, the hallmark for it, there will be formation of a scar for third degree burn. But this is second degree deep, we have superficial, then this is deep partial thickness. This will expand into deeper dermis, where hair frequent gland are involved. There can be hypertrophic scarring. So sorry, we become too fast. But let's turn it back to the slide where we are. Like a third degree burn, or I was saying that for third degree burn, like which is a full thickness burn, there will be a scar formation. Third degree is a full thickness, and remember that once there is a scar that has formed, this is hard skin that is formed. You can confound it with normal skin in the case of a burn. It's anesthetic and hypoaesthetic, not painful. And that here, this is why you have to do a sclerotomy. Fourth degree burn is very simple. It involves once the burn reaches muscle, bones, and tendon. Burn size estimation in children, most of the time it's very important to use around the broader child, where you will be based on age of children, but rules of 9 is accepted in adult, and the palms rule can be used in the children. Remember that if full palm include the finger, it's 1%. If only palm without finger, it's 0.5%. Severity of classification: minor burn, moderate, minor burn. Those are the partial thickness burn that's less than to burn surface area less than 10%, and they are not cross major joint and not circumferential. Moderate burn, to burn is between 10 to 20% to burn surface area, non-critical area. critical burn. This is full thickness more than 10%. Any burn involving hand, feet, or perineum or genitals, circumferential burn, electrical burn, and even once it involves the airway. If there is partial thickness burn and there is more than 20% total burn surface area, those are critical burn. Initial management, you have to remove coughing, assess burn size and severity. You can cool burn area with sterile water. Keep patient warm to avoid hypothermia. Remember incidents because of large body surface area, there are high risk of hypothermia. If in burn involve airway, early sequence intubation is very important. Independent medication and then fluid resuscitation using Parkland formula. This is how you can treat burn based on the classification either if it's minor, moderate, or critical burn. For example, for critical burn, they need immediate burn care by preventive further burn removal jelly, and the ABS approach is very important. Clean the dry sheet or clean the wound dressing. Like for example, in the case of Parkland formula, how do you give a fluid? Example, 3-hour burn with partial thickness burn of 20% and weight 15 kg with normal BP. How much fluid do you give the shot for resuscitation? Type of fluid. Remember, in the burn, the isotonic solution is very important, either injected or normal saline. For Parkland formula, we take 4 ml times total burn surface area times weight in kg, and you get the fluid to be given in 24 hours. Remember, you give the first half in the first 8 hours and the next half in the next 16 hours. And remember to add maintenance IV fluid, which will be D5 injected. So like this one, in the 20 times 15 times 4 will equal to 1.2 ml in the 24 hours. 1.2 liter in 24 hours. First half, which is equal to 600 ml, will be given in 8 hours, equal to 75 ml per hour, which will be injected, followed by 47.5 ml per hour, injected in the next 16 hours. The maintenance, remember, rule of 4 to 1, 4 times 10, we had plus 2 times 5, the child had 15 kg, will equal to 15 ml per hour of D5 injected. You see that our patient in the first hour will receive 70 ml per hour of injected plus 500 ml per hour of D5 injected. At this time, we have to have 2 running IV line. One will be giving that Parkland formula injected, another one will be giving maintenance fluid, D5% injected. This is the case where the patient arrives to you in the first 24 hours. Like if, for example, if a patient arrives to you while it remains only 12 hours or 12 hours has been passed, so you will give all calculated fluid by Parkland formula in the remaining 12 hours. If we arrive to you like in 18 hours, the remaining another 18 hours, you have to give the remaining 2 half, like one half will be given in the 2 hours and the next half in the next 16 hours. So, and once the patient is in shock, for secondary to burn, at that time you have to give bolus IV fluid and continue with Parkland formula. And you have to assess the efficacy of Parkland formula by assessing if normal, for example, if the patient is hypotensive, this is why you have to give a bolus. Then if hypotension is over, to continue maintenance IV fluid by Parkland formula. So in the monitoring output, once urine output is below 1 ml per kg, you can give a bolus also. If we become to family package, this will continue packed and formula. And once you will not put more than 3 ml package per hour, so you have to decrease the pack and the formula. And at that time we have to check glycemia, because it can polyuria can be due to hyperglycemic state, high glycemia, so that can be osmolar diuresis. So this is very important to check glycemia once you have polyuria in the case of burn patient who is on fluid resuscitation. This is very important. So remember pack and formula. So in the case of burn, the important fluid resuscitation, we have a free Jackson burn zone. We have a zone of coagulation, a zone of stasis, and the zone of hyperemia. So once you give enough fluid, you are going to serve zone of stasis. If fluid is not enough, these zones of stasis will become also dead. So to serve it, we have to give enough fluid so that it become it will not be damaged or dead. Like this is an image that showing zone of hyperemia, viable tissue, and the zone of stasis where there is decreased tissue perfusion, and the central zone of necrosis, which is coagulative necrosis. This is dead, so nothing we can do to save it. So fluid are very important. So to monitor fluid status, if a child is less than 30 kg, the normal urine output will be between 1 to 2. If child is more than 30 kg, urine output will be 1 to 2 ml per kg per hour. If less than 30 kg, urine output will be normal if it's between 0.5 ml to 1 ml per kg per hour. So if your output is greater than the goal, test for glucose and may indicate osmotic diuresis from hyperglycemia. I had studied it. Nutrition. So probably burn patient, we need to increase the calorie required per day at basic calorie that the patient has been already taking. Normally have to add something so that we get enough calorie. Pain control, you can use opioids like fentanyl, which is better than morphine, because morphine can cause hypotension. Ketamine also is the best option. And if you burn a patient in hearing burn had pruritus, you have to give antihistamine like diphenhydramine. And usually for pain control, this is the dosage for fentanyl morphine in pediatric patient. Wound dressing is very important. If tray dressing, and you should apply flamazine, or even you can use honey or Ficidin. Systemic antibiotic use is not necessary unless you see there is sign of infection like a fever or the wound is necrotic. So remember to avoid the hypothermia, because hypothermia can cause the depth of burn injury can be increased by vasoconstriction. It can decrease the enzymatic activity, depress muscle reflex, even it can interfere with clotting mechanism, and it can cause arrhythmia and death. You can assess for the need of escharotomy once there is eschar, and even fasciotomy if there is circumferential burn or burn involving a joint. Here we use a Doppler ultrasound. In the case of electrical burn, remember to rhabdomyolysis as myoglobinuria. And remember to dress the burn the wound. Escharotomy should be done often. In deep dermal or in the full thickness burn may form a stiff scar. Those stiff scar will impair circulation or even respiration. So Probably it can be performed by a surgeon, but in rural area, even any clinician can perform it. But for this is sclerotomy, but for fasciotomy requires surgeon. If less than 5 years, more than 5 years, tetanus vaccine is very important. GI protection with either PPI proton pump inhibitor is very important, and even central line is very important if burn surface area more than 25% for fluid resuscitation. Even the albumin chloride can be added for prevent malnutrition. And remember to check glycemia. Check breathing and circulation. In the case of inhalation burn, this is suspected in the case patient burned in necrosed area or present with stridor, hoarseness, drooling, or dysphagia after burn, or had seen like single dinars or vocal cord edema, or burn to the face, or black septum. This can show crude inhalation burn. At this time, early intubation is very important, and they don't use succinylcholine as pre-medication intubation because it can cause hypotension. Here you can use ketamine, which is a stable drug for medication for don't cause hypotension. So remember to use ketamine instead of succinylcholine. And that intubation, probably intubation can be difficult due to airway edema, which resolves in 3 to 5 days, but it peaks at 24 to 48 hours. And you have to monitor the position of endotracheal tube either by capnograph or chest X-ray. This is another type of burn, like electrical burn and high voltages for more than 1000 volt. And in that case, that should be, remember, electrical burn had the entry and exit point, and it can be associated with arrhythmias. So ECG is very important in the case of electrical burn. And there is aggressive fluid resuscitation, and they can give a monitor to prevent osmotic diuresis. In children, they tend to have labial commission burn, where this labial artery is affected or destroyed, so that most of the time it happens at the angle of the mouth where that artery is located, as mentioned in this picture. So in the case of burn, also remember child abuse is very important. Most of the time, like if a burn, children presented like in this picture, think about child abuse. Like those images, they are in favor of child abuse. As a summary, remove chlorophene to stop burning process. You have to assess burn quickly for extent and depth. Rapidly begin fluid resuscitation, pain management, and high index of suspicion of about child abuse. Thank you very much for kind attendance. You are welcome. Remember to subscribe to our YouTube channel.